So the clinical examination rheumatology really incorporates three issues. We look, we feel, and we move. Okay? So looking, basically when we see the patient coming into the consulting room or see the patient walking towards you, you watch for their posture and you look at their gait. With their posture could be, with a flexed spine, or it could be, a limp or whatever. There are many reasons why you could get changes like that. The other issues that we look for are basically skin changes, any curvatures, like for example spinal curvatures, for example. Are there any scars indicative of previous surgery? Are there any swellings or any deformities? So we look really for this list of problems when we actually examine a joint. Then we feel for trigger points, which you can get, for example, with fibromyalgia. We look for any warmth, or is the joint hot, or is it warm or hot, or is it inflamed? We then look for muscle tenderness around the joint, and then we also look for joint line tenderness, and we look for swelling as discussed, and we try to evaluate whether there's crepitus or not. And then when we move, there are really three movements. We have active movement, which is performed by the patient. In the case of the shoulder joint, we can ask the patient to flex their shoulder, to abduct their shoulder, or to internally rotate their shoulder. Then the doctor passively moves the shoulder, where the doctor, for example, will, in the case of, say, a painful arc, will try and actually abduct the shoulder themselves. They will try and establish whether it's a acromioclavicular joint, where you try to, when you do the scarf test by throwing their arm over, it compresses the ACJ and they can get discomfort or pain from it. And then if you want to, rotate the actual shoulder joint internally using subscapularis tendon, and you can also laterally rotate the shoulder, which is a pathognomic of infraspinatus tendinitis. These are the sort of movements that you do from a passive point of view. And then it's important to check the actual tendons with resisted movements. For example, in shoulder joint again, resisted movement of the supraspinatus, where you actually ask the patient to abduct their shoulders to about 30 degrees, not beyond that, because then delta takes over from there. At 30 degrees, we check the integrity of the supraspinatus tendon bilaterally. Then we actually check the infraspinatus tendon, and to actually check the infraspinatus tendon, we ask the patient to to laterally to rotate their arm. So we catch their forearms at both sides, and we ask them to push out against. So you're checking the integrity of the infraspinatus tendon, and similarly you can check for the integrity of the subscapularis by again asking the patient to flex their elbows, extend their forearm, and ask them to actually medially rotate against resistance. So you're checking the subscapularis tendon by doing that. So we have again active, passive, and resisted movements. So to recap, we look, we feel, and we move, and moving consists of active, passive, and resisted movements. Okay?